Hello, good evening.
Hello, good evening, Dr. Isha.
Yeah, how are we doing?
Please, we are fine, thank you.
Yeah,
And
fine. How fine.
Yeah, I'm also doing well. Okay. What did we discuss the last time we met? Was it diarrhea or was it another topic?
Diarrhea.
Okay. Did we finish?
no, please. We are here to handle the management.
Okay. All right. So we did the various types of diarrhea, the diagnosis, clinical manifestations. But we are here to do the management.
Yes,
Okay. So,
please.
all right, that's fine. So for the management, for every management, you know very well we have non-pharmacological and pharmacological. So we start with the non-pharmacological management. Then we scale our attention to the pharmacological. So before we even talk about the pharmacological and non-pharmacological, what are some of the treatment goals we want to achieve at the end of the management? Any ideas? Some of the treatment goals you want to achieve at the end of managing diarrhea?
To prevent dehydration.
Yeah, so to prevent dehydration. Yeah. So that's one management treatment goal. What again?
To correct any electrolytes or fluid losses, to replace them or
Yeah,
something.
exactly so. So the ones that have been lost, you want to replace lost fluids and electrolytes, and you want to prevent any further dehydration. So you mentioned two treatment goals. Any other? Any other treatment goal? So you also want to prevent complications. So dehydration is one of the complications. You could also have electrolyte imbalance, like hypokalemia, hyponatremia. All these are complications. Diarrhea can lead to AKI. So pre-renal AKI, you can become dehydrated, and that can lead to reduced perfusion to the kidneys. So all these are complications. You also want to maintain adequate nutrition. So during diarrhea, patient may not be getting adequate nutrition. They may be vomiting. Almost everything they eat is coming out. So for patients who are not able to tolerate oral, you may want to do IV nutrition for them. So that can be done. Those who can tolerate oral, you want to make sure that they eat adequately. Then you also want to improve their personal hygiene. So you want to ensure that personal hygiene is improved, because if they are trying to manage diarrhea and they are also inoculating themselves, they visit the washroom, they don't wash their hands very well, they can introduce more pathogens, and that can prolong the duration of the diarrhea. So personal hygiene is very, very important. You also want to improve their quality of life. And as usual, for every treatment goal, you want to relieve the symptoms, improve quality of life, prevent complications, and also reduce morbidity and mortality, especially in children below 5 years. They usually tend to die from diarrhea. And the most common cause of death is because of dehydration. So you also want to be sure that adequate fluids and electrolytes are replaced. All right. So for the non-pharmacological, what are some of the things that can be done for the patients? Any ideas? The non-pharmacological, what do you want to tell the patient?
The patient should take in a lot of fluids.
Yeah, so as one of the non-pharmacological advice, you want to tell them to increase their intake of fluids. Because during the diarrhea, they lose a lot of fluids. So you want to encourage adequate fluid intake. What again?
You also want to tell them to improve their personal hygiene, such as the washing the hands before they eat.
Yeah, so that's also very true. So you see some of the non-pharmacological are targeting the treatment goals. So we mentioned I am taking enough fluids, and that's non-pharmacological. Improving personal hygiene by washing hands is also non-pharmacological. What again? What again? In terms of their food, what type of food should they take?
We can take porridge for the start.
Yeah, so preferably you may want them to take a lot of home-based fluids. So in a form of porridge, it could be rice water, could be light soup, anything watery, just to increase their fluid intake. So you can recommend cocoa, rice water, light soup. All these are water-based foods they can take. And aside that, they can also take adequate fruits and vegetables, increase their fiber intake. All these can help. All right. So assuming you're at home, one of the treatment goals is we want to prevent or we want to neutralize. So usually you want to give something like ORS. But if you don't have ORS at home, how can you prepare home-based ORS? So if you want to prepare home-based ORS, how can you prepare? Anyone?
So for the home-based ORS, use the 6 teaspoons of sugar and half teaspoon of salt, and you're going.
Yeah, so that's true. So if you don't have the commercially available ORS, you can actually prepare a home-based ORS. You need a 6-level teaspoon of sugar and half teaspoon of salt in 1 liter of boiled water, which is made to cool. So that's how you prepare home-based ORS. And you can give it to the patient or to the child as and when they have a loose stool. But if the patient is not able to take within 24 hours, you discard the rest. So if they take maybe half of it, 500 ml, the remaining half, we can keep it in the fridge, but it shouldn't go beyond 24 hours. So that's how you go about preparing home-based ORS. So that can also be added as non-pharmacological way of managing diarrhea. Now for the pharmacological, we would talk about this in terms of the various causes. So we start with viral. So for viral, usually we said patients will present with diarrhea, they may be vomiting, low-grade fever, there will be absence of blood and mucus in stool. Typically, such patients only require hydration. So there's no need for any antibiotics or any antiviral agents. So if it's viral, you don't give antibiotics, you don't give antiviral agents. You only do hydration. And the hydration will be dependent on the severity of dehydration. So when we're talking about the clinical symptoms, we mentioned that dehydration can be classified into 3. So we have mild, moderate, or severe. So these are the levels of dehydration. So how severe the dehydration is would tell us whether to use oral hydration or to go for parenteral hydration. So if you are going for oral hydration, the preferred oral hydration is the commercially available ORS. And what is the composition of ORS? You can tell us the composition of ORS. Anyone?
For ORS, we have anhydrous dextrose, sodium chloride, potassium chloride, and sodium citrate dihydrate.
Yeah, so that's true. So anhydrous dextrose, sodium chloride, potassium chloride, and trisodium citrate dihydrate. So the ORS is not just replacing fluids, but it's also replacing electrolytes. So you can see sodium in there, you can see potassium, you can see chloride. There's a dextrose component to provide some level of nutrition and all that. So ORS is very vital during during the management. So when you take one sachet of ORS, how much water are you going to dissolve it in? And how should it be given? Anyone to tell us? So if you look at the commercially available ORS, realize that most of them, you take one sachet of the ORS and dissolve it in 500 mils of water. So if you need 500 mils of water, just one small Vortic bottle is 500 mils. So you dissolve one sachet of ORS in there. But I think when you look at the STG talks about 600 mils. So that's two Coke bottles. So the one in the glass. So the Coke in the glass, I think one is 300 mils. So two Coke bottles should give you 600 mils. So that can also be used, but it's dependent on the manufacturer. So some are 500, some are 600. Aside so if you mix it, depending on the age of the child, if it's below 2 years, you would have to give 50 to 100 mils of the mixed ORS as and when the patient has a loose stool. So you give 50 to 100 mils when they have a loose stool. If they're above 2 years, you do 100 to 200 mils of the ORS after each loose stool. So you keep giving it as much as the patient can take. So if you mixed one and they've finished it, you can mix another one. So as much as they can tolerate, you keep giving. But one sachet should go with 500 ml or 600 ml, depending on the manufacturer. So that's for people with mild dehydration. For people with moderate dehydration, you want to start with ORS first. So you keep giving the ORS, then you assess within 4 hours. After 4 hours, if the patient is very much okay in terms of the level of dehydration. So we talked about some of the signs of dehydration. The eyes could be sunken, the skin will be dry, the mucous membranes will be dry. So the dry mouth, dry tongue, dry lips. So in terms of tears too, they have dry eyes, they are not producing tears. Then you can check for skin turgor. So you have reduced skin turgor. Capillary refill time too would also be increased. Typically, want it less than 2 to 3 seconds. But if they are dehydrated, it will be more than 3 seconds. Then you're also looking at urine output, whether it's reduced, and the ability to drink. So for mild, there wouldn't be any signs of um, they being thirsty. So they are able to drink normally. But moderate, they are very thirsty, they are eager to drink. Very severe, they are thirsty, all right, but they are too weak to drink. So there's lethargy. So such patient may need IV hydration. So you need to assess. So for moderate, within 4 hours, you start your ORS. After 4 hours, if the dehydration has improved, you can continue. However, if it's still severe or the dehydration is still there, it's not really improved, then you can move to IV hydration. So that's for moderate. And the very severe ones, you don't go for oral because the patients are too weak to even drink. So such patients, you don't start with ORS, you rather start with IV hydration. So you start with IV hydration. As and when they are able to tolerate oral, you add on the oral hydration, but you start straight away with IV hydration and you assess based on response. So all these are ways of managing dehydration. You categorize or stratify your patient. So depending on how severe, patient may be given treatment plan A, which is basically ORS, treatment plan B for patients who have moderate. So you may do ORS after 4 hours. If they are not responding, go to IV. If they are responding, then you can continue with your ORS. For the very severe one, that's treatment plan C. You do IV hydration. So that's how you replace the lost fluids and also prevent dehydration. Any questions? Okay. So in terms of the IV hydration, which IV fluids can be used? So the infusion of choice, which one is the preferred infusion you can use when you want to replace lost fluids in diarrhea?
Ringer's lactate.
Finger lactate.
Yeah, so Ringer's lactate. Ringer's lactate. And you are using Ringer's lactate because it has most of the electrolytes and also going to replace the fluids for us. One of the major electrolytes we are concerned about during dehydration is or during diarrhea is potassium, because hypokalemia can be very detrimental. You know, the risk can lead to arrhythmias. So we don't want to have hypokalemia at the same time battling with diarrhea. So as much as possible, we want to give an infusion that has quite an amount of potassium in there just to replace the electrolytes and also replace the fluids. So aside ringers, what again can we use?
Normal saline.
Yeah, normal saline can also be used. So if the electrolytes are normal, the potassium is normal, you can use normal saline. But if it's borderline, they are going into hypokalemia, ringers is the treatment of choice. Okay, aside these two, any other agents in terms of the fluids? Any other fluid we can use?
You can also
Cholera
use
replacement fluid.
Yeah, so cholera replacement fluid. So cholera replacement fluid 541. So if you hear of infusion 541, that is a cholera replacement fluid. So what does the 541 stand for?
so the 5 grams is for sodium chloride, the 4 grams for potassium chloride, and the 1 gram is sodium bicarbonate.
Okay. Are you sure? Is there any other contribution? So the 5 gram is what? Sodium chloride. But the 4 gram is what?
Sodium bicarbonate.
Yeah. So you exchange them. So 5 grams is sodium chloride, the 4 grams is sodium bicarbonate, and the 1 gram is potassium chloride. So that is the cholera replacement fluid 541. So it can also be used usually for patients who have cholera. But aside cholera, it can still be used for other forms of diarrhea because of the ingredients you have there. Okay, what again?
And so you can also do dextrose saline, especially if the person is not able to eat.
Okay, but most of the times you try as much as possible to avoid dextrose. Why do you avoid dextrose? Who can tell me? Any reasons why you avoid dextrose? Is anyone trying?
It can increase the diarrhea.
Yeah, so dextrose is osmotically active. So in terms of its ability, it's able to draw water. So if the issue is more with oral glucose when you are taking oral dextrose. Remember we talked about the types of diarrhea, osmotic diarrhea. Osmotic diarrhea, if you take in any osmotically active substance, it can draw water into the gut and increase the diarrhea. So as much as possible, we try to avoid dextrose containing infusion, unless maybe the patient is going into hypoglycemia, then we want to give some dextrose. Even that, you want to give something like DNS so that you don't dehydrate the patient. So DNS may be preferred in such instance unless it's an established hypoglycemia that needs to be managed quickly. Then you want to go in for the high percentage dextrose. But if it's just to maintain nutrition and also provide hydration, you want to go for something that is not hypertonic. So DNS, which has 5% dextrose, will be okay to do the nutrition and also hydration. So aside the ringes, the cholera replacement fluid, normal saline, what again can we do? So there's an infusion, those are child health. I don't know if you've come across Darrow's infusion, half-strength Darrow's. So there's an infusion called half-strength Darrow's. It's similar to ringes in terms of the ingredients, just that it has a higher concentration of potassium compared to ringes. So that can also be used as part of the infusions for diarrhea. So if you don't have ringes, you can use Darrow's infusion, half-strength Darrow's. So these are the infusions of choice if you are trying to manage diarrhea. So in terms of treatment plan C, the severe hydration, you can do any of these. You usually want to start with 100 ml per kilogram start, then you monitor as and when you need to give more, then you give. If the patient can tolerate orals too, you can do orals alongside the IV hydration. And you also want to assess for urine output. So you just don't give you give a monitor. So you give and monitor the urine output so that you
So,
don't overload the patient as well.
hello, sir.
Hello?
Please, are we doing the severe management for severe dehydration right now?
Yeah, that's what we are doing. You only do IV for severe.
Please take it again.
Which part should I take it?
For severe dehydration, please.
So basically, I said that one is IV hydration. So I've mentioned the IV hydration of choice. Ringer's, normal saline, half-strength Darrows, and cholera replacement fluid. So you always have to assess based on the level of dehydration. Does the patient qualify to be given IV hydration, or the patient needs oral hydration? So if it's severe dehydration, very sunken eyes, they have very dry eyes in terms of skin texture, very reduced, very low urine output, lethargy, patient is not even able to drink water. So such patients, straight away, you know they need what? IV hydration. And I said for the IV hydration, you give ringers because ringers tend to have almost all the things that you need because there's sodium in ringers, there's potassium, there's chloride, there's lactates, calcium, you have everything in there. So that's the infusion of choice. And typically you start with 100 ml per kilogram. So if it's ringers 100 ml per kilogram, if it's not available, then you can consider normal saline, the cholera replacement fluid, or half-strength DARPs. And for the IV hydration, you need to be assessing. So if maybe after an hour or two, patient hydration status has improved, then you may also want to add ORS. But if it's not improved, then you stick to doing the IV hydration. Is it clear?
Yes, please. Thank you.
Okay. Now let's talk about bacteria. So for bacterial causes, we said typically patient will present with diarrhea, there may be vomiting, there may be fever, and you also have blood or mucus in stool. It's not always the case that you have blood or mucus, but generally for bacteria diarrhea, you have fever present, which is very significant. And you also have the diarrhea happening, there may be vomiting. So for such patients, you want to consider an empirical antibiotic. So the IV hydration cut across for everyone. So whether viral, protozoa, bacteria, IV hydration and oral hydration cut across. However, depending on the cause, if it's viral, you don't need antibiotics, you don't need antiviral. But if it's bacteria, then you need to give some empirical antibiotics whilst you are wait for your culture. So maybe you took samples, stool, stool samples for culture. You are waiting for the lab. It may take up to about 5 days or so. So you want to start an empirical treatment based on the common organisms we mentioned. So remember we mentioned E. coli, Shigella, Salmonella, Campylobacter, and all that. So you want to give antibiotics that may have coverage against these organisms I've mentioned. So in our setting, one of the common antibiotics we give for bacterial causes is Cipro. So for Cipro, it covers a lot of these organisms, Salmonella, Shigella, E. coli. It tends to cover almost all of them. So you give Cipro empirically. Whilst you are waiting, it can be that after the culture, Cipro is even resistant. But you want to give empirically whilst awaiting. It could be that the Cipro can clear everything. So you may not even need to switch. So that's the purpose of giving the empirical. For the community setting, Cipro is preferred if you suspect bacteria. So you can do oral Cipro, usually 500 milligram BD for 5 days. That can be done. If you are not sure whether you are dealing with bacteria or you are dealing with protozoa, because bacteria and protozoa, they may have mucus in stool, they may be vomiting and all that. So you are not sure. You can do something like Ciproless TZ, which has Cipro and also tinidazole. So Cipro to cover for the bacteria and tinidazole to cover for possible protozoa. That can be done in the community setting. However, if you are sure it's bacteria, then just go in for Cipro without the tinidazole component. For the hospital setting, you can also do Cipro. Aside Cipro, you could also do cefprozime. So cefprozime can also be done, typically 750 milligram TDS for adults. So you can start with that whilst awaiting cultures. So these are antibiotics you can routinely do as part of your empirical. However, depending on the organism, there are some specific antibiotics that are sensitive for specific organism. So in cases Salmonella that was isolated or patient came, there's blood in stool, there's mucus in stool, you ask about the color of the stool and they are telling you their stool color is greenish. So if they tell you they are having greenish stool, one of the organisms you should suspect is Salmonella. So you may want to do an antibiotic which is very sensitive against Salmonella. So in terms of the antibiotics, which one would you want to give if you suspect Salmonella? Any ideas which of the antibiotics you want to give? Salmonella typhi. Very common antibiotics you can give. Cipro is very sensitive. You can also do Septrin. So you can do Septrin, usually 960 BD for 5 to 7 days. You can do ceftriaxone if you are in the hospital setting. So you can do ceftriaxone. And this antibiotic, furazolidine. So furazolidine. So when you look at Metroles F, so the F there is furazolidine. It's also sensitive against Salmonella. So these are some of the antibiotics you can give if you are suspecting a Salmonella: Cipro, Septrin, ceftriaxone, furazolidine. If you are suspecting Campylobacter, so for Campylobacter jejuni, typically they respond well to the macrolides. So instead of doing the Cipro, you may want to do erythromycin or azithromycin. So for Campylobacter, the drug of choice is erythromycin or azithromycin. If you are suspecting Shigella, so for Shigella, typically it will also do blood in stool, mucus in stool. If you are suspecting that, the antibiotics that are used for Salmonella are also sensitive to Shigella. So Cipro is sensitive, Septrin is also sensitive, then furazolidine is also sensitive. So for Shigella, you can give these antibiotics. So depending on the things that you are suspecting,
So please
assuming they
mention
come in,
the
they tell you
medicines again
for which of them.
for Shigella.
So for Shigella, I said Cipro, Septrin, and Furazolidine. So it's basically the same antibiotics that are used for Salmonella. So Cipro, Furazolidine, Septrin, they are all sensitive against Shigella. If they come in and they are complaining of rice water stew, they are vomiting, their stool is explosive, you think about possible cholera. So Vibrio cholera. So for cholera, usually the tetracyclines. So you can do tetracycline. You can also do doxycycline. So if you don't have tetra, you can do doxycycline. But aside these two, the other agents like Cipro and Septrin are also sensitive against Vibrio cholera. So that can also be used. But the drug of choice are usually tetracyclines. So tetracycline or doxycycline. Okay, so that's how you manage bacterial causes. So generally you give empirical, but if you have suspicion of cholera, you may want to do tetracycline. If you have suspicion of salmonella, maybe Cipro. If you have suspicion of Shigella, you can do Ciproceptrin. If you are thinking of Campylobacter, then you do azithromycin or erythromycin. So these are specific antibiotics against specific organisms. All right. So if you also have protozoa, we are managing protozoa. Usually you want to find out certain questions. Do you have fever? If they tell you there is no fever, then it's likely to be protozoa. So if there is mucus in stool, but there is no fever, the patient is having watery stool, there's vomiting, you think about protozoa. So for protozoa causes, we mentioned the common pathogens implicated. So E. coli, no, E. histolytica. So Entamoeba histolytica and Giardia lamblia. These are the protozoa causes, very common ones. So for the protozoa, typically we want to do agents with anti-protozoal activity, like the nitroimidazoles. So you can do metronidazole, you can do tinidazole, you can do secnidazole. All these are active against Entamoeba histolytica and also the Giardia lamblia. So for metro, you usually do high doses for Entamoeba histolytica, 800 milligram TDS for about 5 to 7 days. So that's how you manage protozoa. But in everything, don't forget your hydration. So your ORS and also your IV hydration, depending on the severity. Any questions? Okay. So that's how you manage the various types of diarrhea, whether it's bacterial, viral, or protozoa. So for patients who you've ruled out possible infectious diarrhea, so there is no fever, there is no blood, there is no mucus, so they are just having diarrhea. So maybe they are traveling from Kumasi to Accra and they feel like almost every time they want to go to the washroom. So possible type of diarrhea will be traveler's diarrhea, because when they go, they don't see blood, they don't see mucus, there is no fever, there is no abdominal pain, there is no signs of infection. For such patients, you can consider anti-motility drugs. So the common anti-motility drug we use is loperamide. So such patients, you can consider giving loperamide. And basically, it's going to slow transit through the GIT and allow time for more fluid to be absorbed. So basically, that's how they act. They are just going to cause the GI transit time to increase. So the rate will be reduced, but the transit time will be increased. And such drugs can cause constipation if you don't take it well. So usually do loperamide 4 milligrams start, and you do 2 milligram when required. So you can do 4 start and 2 milligram when required. If you stop taking it. However, if it persists for more than 48 hours, then it's likely that there could be other causes. So you may need to investigate further. But if it's traveler's diarrhea, you take loperamide within 48 hours, the diarrhea should stop. Aside loperamide, there are other antimotility drugs that can be used. So we have codeine. So you can use codeine, and you could also use bismuth subsalicylate. So bismuth subsalicylate, all these help with diarrhea. So these are for non-infectious diarrhea. All right. Any other questions or anything you want to find out?
Hello, sir.
Yeah.
Good evening.
Good evening.
Sir, please, in the hospital settings, is the use of loperamide ideal? Because I am thinking that normally a culture sensitivity will be done to know the causative organism and knowing the side effects of loperamide. Would it be ideal?
Yeah, so loperamide is ideal in patients who do not have infectious diarrhea. So you could have a patient at the ward having diarrhea, but the diarrhea may not be infectious. There is no signs of infection. There is no fever. There is no blood. There is no mucus. There is no abdominal pain. In such patients, it's okay to give loperamide. But you should always consider hydration. So the loperamide is just to stop, but the lost fluids electrolyte needs to be replaced. We avoid loperamide because if it's infectious and you are giving loperamide would stop the diarrhea and would retain the infectious pathogen. The diarrhea is a form of clearing the infectious pathogen. So if you are retaining the infectious pathogen, it prolongs the course of the illness. You know, some of these pathogens produce toxins. So it may produce toxins that may further cause detrimental effects. So as much as possible, you want to rule out infectious diarrhea. If it's not infectious, loperamide can be given.
Okay, thank you, sir.
Okay.
Please, how much of the IV fluid should be administered in severe diarrhea?
Yeah, so for severe diarrhea, I mentioned that usually you start with 100 ml per kg. So depending on the weight of the patient, but you divide it. So usually you do 30 ml per kg within the first hour, then 70 ml per kg for 5 hours. So within 6 hours, we expect that you should have given 100 ml per kg. So that you also monitor. So if you are giving that 100 ml per kg and patient is becoming edematous and all that, you need to stop. So it's patient specific, but generally 100 ml per kg divided into two, 30 ml per kg within the first hour, then 70 ml per kg for the next 5 hours. Okay. The other thing you could also consider, aside the oral ORS and all that, one of the important medication is zinc supplementation. So zinc supplementation is very essential, especially in children. Children below 5 years is very essential. So for zinc supplementation, WHO has recommended that for children with diarrhea, you don't just give ORS, you give ORS with zinc. And zinc supplementation has been shown to reduce the duration of diarrhea by 25%. So in terms of duration of diarrhea, when you add zinc, it's been shown to reduce the duration of the diarrhea by 25% and also reduction in stool volume by 30%. So we are looking at reducing duration of diarrhea by 25% and reducing the stool volume by 30%. So that is the main reason for adding zinc supplementation to ORS. But aside that, it also helps boost the immunity. It also helps with intestinal transport of water and electrolytes. Then it also helps improve the function of the brush border. So the brush border is where you have absorption of nutrients and also fluids. So at times during diarrhea, especially inflammatory, it destroys the integrity of the brush border. So you give zinc supplementation, it also improves the function of the brush border and also boosts the immunity. And we are also saying it reduces the severity of the diarrhea by reducing the stool volume by 30% and also reduces the duration by 25%. All right. So for children below 6 months, you want to do 10 milligram daily of zinc supplementation for 10 to 14 days. And those above 6 months, you want to do 20 milligram daily also for 10 to 14 days. So that's how you manage the diarrhea with zinc supplementation. But for adults, generally, we don't need zinc supplementation. We get it from our diet, we have enough levels. But children may be deficient. So you want to do zinc supplementation in children below 5 years. Any questions?
Hello, sir. Please, can you take the place for
So I think we've covered most of the things about diarrhea. Let me just briefly talk about amoebiasis. So for amoebiasis, it's so there's intestinal manifestation and extra-intestinal manifestation. So it does two clinical manifestations. And this is because the entamoeba histolytica exists in two forms. So there's the vegetative form, which is the trophozoites, and there's the cyst form. So it exists in the cyst form and also the trophozoite form. The cyst form of the entamoeba histolytica stays within the lumen. So when you do a stool culture, when you take stool samples, you see the cyst form of the entamoeba histolytica. However, the trophozoite form is invasive, so it's able to move from the lumen of the intestine and go to other organs. So the trophozoite form is what is going to cause the extra intestinal manifestation, whereas the cyst form is infective.
Hello.
It causes the... Hello?
Hello. Dr. Ishak, could you kindly start again?
Why you weren't hearing me?
Yes, please.
So I was talking about amoebiasis. Can you hear me now?
Yes, please.
I said amoebiasis presents in two main forms. So you can have intestinal manifestation and extra-intestinal manifestations. So for intestinal manifestation, that is the diarrhea. So that's amoebic dysentery. So the diarrhea you have is the intestinal manifestation. But you can have extra-intestinal manifestation. That's beyond the intestine. So that's why we call it extra-intestinal manifestations. So I was saying the entamoeba histolytica exists in two main forms. We have the trophozoite form and we have the cyst form. The cyst form is said to be infective. So that is what is going to infect the lumen of the intestine. So when you take stool samples to do culture, what you see in the stool is the cyst. So if the patient goes to the washroom and after everything, they don't wash their hands and they go and eat with other people, what is going to infect other people is the cyst form, because that's what's in the lumen. So the cyst form is the infective form, whereas the trophozoite form is the invasive form of the entamoeba histolytica. So the invasive form moves beyond the intestine to affect other organs. So in terms of the extra-intestinal manifestation, the amoeba or the entamoeba histolytica can affect the brain. When it affects the brain, it causes amoebic cerebral abscess or amoebic brain abscess. So that is the manifestation when it gets to the brain. When it goes to the liver, it can also cause amoebic liver abscess. So you can have amoebic liver abscess when it gets to the liver. Then when it affects the lungs, it can also cause amoebic lung abscess or amoebic empyema. So that is also the pulmonary manifestations. So these are the common extra-intestinal manifestations amoebiasis can cause. So whenever you have amoebiasis, you don't just think about the diarrhea. Think about other possible extra-intestinal manifestation like the amoebic brain abscess, amoebic liver abscess, or amoebic empyema or lung abscess. So this is caused by the trophozoite form. So for that reason, if you are managing amoebiasis, the management comes in twofold. We have drugs that target the cyst forms of the entamoeba histolytica and drugs that target the trophozoite form of the entamoeba histolytica. So when you give metronidazole, the purpose of giving metronidazole is to clear the trophozoite form. So metronidazole is absorbed. When you take oral metronidazole, it's absorbed and that can get to the systemic tissues to clear the trophozoite forms. However, for the cyst form, you need something that stays within the lumen of the gut to be able to clear the cyst form. So in managing amoebiasis, after metronidazole, you should follow it up with another agent. And these agents are known as intraluminal agents. So we call them intraluminal agents. We are calling them intraluminal agents because their action is localized within the lumen of the intestine. So we call them intraluminal agents. And these intraluminal agents, the common examples are dilozanine furoate. So we have dilozanine furoate. So I'll type them in the chat box. So dilozanine furoate. Then we also have paromomycin. So we have paromomycin, which is an aminoglycoside. Then we also have iodoquinone. So these are the common intraluminal agents that we have. So dilozanine furoate, paromomycin, and iodoquinone. So after giving the metronidazole to clear the trophozoite form, if you don't give any agent to clear the cyst form, the cyst form will grow to become the trophozoites and also move to the extra-intestinal places that we talked about. So we want to clear the trophozoite first, then after that we clear the cyst form with the intraluminal agent. So for amoebiasis, take note that you are not just managing the trophozoite with the metronidazole, but you also need to clear the cyst form with your intraluminal agents. Any questions?
Please, for how long should the metronidazole be done in this case before starting the intraluminal agent?
So in terms of the treatment, it's 5 to 7 days. So you do metronidazole for 5 to 7 days. Then you follow it up with the luminal agent. And usually that one too is about 10 days. So if you are doing dilozanine furoate, you would have to do 500 TDS for 10 days. Any other questions? Okay. All right. So if there are no other questions, I think we'll end here. Our next meeting, we'll go through some questions on the diarrhea, and we'll also start with constipation. Have a good evening.
Thank you, Dr. Ishak. Have a good evening too.
Okay.
Hello, class. Please don't log out. Please don't log out. Hello, please can you hear me? Hi.
Yes, we are here.
Hi.
Oh, thank God. Good evening to everyone.
Good
Good
evening.
evening.
Please, yes, please, I want to encourage all of